Let's talk about hypertension and its sort of twisted, toxic relationship with arteriosclerosis and how they can feed back to one another and create this positive feedback loop. We'll then go into the different types of arteriosclerosis with an emphasis on atherosclerosis, and then delve a little bit into how damage to the vessels can lead to aneurysms and dissections and potentially ischemic heart diseases like heart attacks. So hypertension, usually we're going to say it's around 110/70, 120/80. Obviously, the top number is systolic when the heart is contracting. Lower number is the diastolic when the heart is relaxing. Arteries are elastic, so there's sort of these pressure reservoirs. Hypertension is more common in African Americans. People who smoke is actually particularly high for hypertension, obese individuals, and there's also a strong genetic link. We typically measure it on the brachial artery, but really most of the arteries should be more or less equivalent in what their blood pressure is. A couple different stages of hypertension. We'll really just be concerned with this one. So anybody who has a blood pressure of 139 systolic or larger is technically hypertensive, or if the diastolic pressure is 90 or larger. And amazingly, over 47%, so about half of Americans have hypertension. Obviously, it can go to stage 2, and then hypertensive crisis, something you should know, over 180 or over 120. And then there's two types. There's an emergency hypertensive crisis. The emergency is where there's acute end organ damage. The hypertension is so bad it's damaging the organs. And then the urgent one is where there is not immediate end organ damage. Types of hypertension, so primary or essential hypertension. So this is like 90% of the hypertensions we're going to be interacting with. Most of these are just age related. Just as people get older, their vessels become crappier, their heart becomes crappier, and we develop hypertension. And so just increased cardiac output and total peripheral resistance. And there's just many factors that will integrate to form this. So we kind of just shrug our shoulders and say it's idiopathic for the most part. It's just entropy. But then some people have very specific targets that we can point to that caused their hypertension. This is secondary hypertension. There's a couple different ones. I mean, you could have like a pheochromocytoma. Someone has like an adrenal medulla cancer, and it's just generating tons of catecholamines that are causing massive vasoconstriction. That's one, but probably the main one you should think about is renal artery vasoconstriction, where it's now just for whatever reason overproducing renin, which is going to activate the ROS system, which causes hypertension. Things that contribute, we talked about the many factors that integrate to cause primary hypertension. Let's go through them one by one. And it may be helpful to remember that pressure is equal to flow times resistance. So if the flow or the resistance goes up, the pressure should go up as well. So let's look at things that increase the flow, basically. And this is specifically going to cause higher diastolic. So smoking is a huge one. This is going to increase the heart rate, which increases the cardiac output. Obesity, it can stimulate the ROS system. ROS, one of the end products is aldosterone. Aldosterone means more water retention. More water retention means more preload. More preload means more cardiac output. ROS also increases the contractility of the heart. Obesity itself can also lead to hyperlipidemia, which is specifically going to contribute to atherosclerosis. Excess salt intake is going to cause very similar mechanism. More sodium means more water is reabsorbed, which again, just same thing as we saw here. We're going to have more preload. Now, what about the resistance side? This is going to contribute to higher diastolic and systolic pressures. So smoking can vasoconstrict arteries. Also damages the arteries, and if they're damaged, it's going to make them more susceptible to all versions of arteriosclerosis, but especially atherosclerosis, which can then positively feed back and cause more hypertension. Obesity, as we said, activates ROS. ROS causes vasoconstriction. This is going to increase the total peripheral resistance. Stress activates the sympathetic nervous system, which, in addition to increasing the heart rate, is also going to cause vasoconstriction. And then the diabetes, high blood sugar can damage the vessels, which can cause arteriosclerosis, a specific kind called hyaline arteriolosclerosis. And this is just showing that hypertension, most of it is primary. It is just a shrug of the shoulders saying, I don't know, people just get old and they break down and their vessels break down and hypertension develops. Secondary hypertension, like renal stenosis, is one way that you could have your kidneys overproducing renin, and you get this like string of beads appearance on your renal arteries. So that's a big giveaway. So why is hypertension bad? Let's just think about it in two domains. It damages and stresses the heart, and then it damages the endothelium. So if there's a lot of afterload, the left ventricle has to pump harder, and over time it remodels and it hypertrophies. So we now have left ventricular hypertrophy due to the afterload. This leads to heart failure, both diastolic because it has trouble filling because it's so large, and systolic because it's just the afterload is too much for it to fight. Now this left ventricular hypertrophy, now that it's particularly large, the idea that there's heart failure due to the diastolic and systolic causes we just mentioned, plus the fact that a large heart kind of squeezes the coronary arteries, compresses them, so less blood is going to get to the heart, plus a large heart has an increased oxygen demand. All of these three factors are going to lead to coronary artery disease, ischemia, and potentially myocardial infarction. Additionally, the remodeling of the heart changes things like conduction velocity, the repolarization, the refractory period, etc., and asymmetries in these traits for different cells in combination with the ischemia that we mentioned in the non-conduction scar tissue island is going to lead to things like reentry circuits. It might lead to ectopic foci. All of this is just going to contribute to arrhythmias. So damage to the endothelium, this predisposes individuals to clots, specifically because the endothelium, if it gets damaged, the endothelium is necessary to generate thrombomodulin, tissue plasminogen activator, and heparin sulfate, all of which are anticoagulants. And so if we damage the endothelium, one of its jobs is to make these, and we don't get these, which means we have more clotting. Just in general, it's going to weaken we see all of that here. It's going to weaken the vessel walls. So just hypertension, too much pressure is just bad for the walls. It damages them. This can contribute to aneurysms and dissections if we have a weakened wall. Promotes arteriosclerosis. So this is what an artery should do. Notice it's elastic and it stretches, right? And a rubber band is elastic. It stretches, but then it snaps back. But here we don't even have the stretching in the first place for arteriosclerosis. So if these are particularly stiff, we don't have the pressure reservoir, which means the pressure goes right through. So we're going to have a really high systolic pressure because it's not giving any, and this is then going to feed back and cause more hypertension. Means we're going to have more arteriosclerosis, means we have more hypertension, etc. Additionally, this is just going to more afterload, more hypertension means that we're going to further stress the heart, so it's feeding back there as well. Arteriosclerosis also contributes to atherosclerotic plaques, which lead to clots. Clots lead to strokes and coronary artery disease. This also is something that's contributing to the issue we had here with coronary artery disease and the trouble feeding the heart, right? So the heart is large, so it requires a lot of oxygen. The coronary arteries are compressed. It's failing. On top of this, now we got all these plaques, which are limiting blood flow. This is just further going to contribute to the MI. It's a silent killer. Most people just don't really know or worry about their hypertension. Like we saw, 50% of Americans have it, and over time it can lead to heart attacks and strokes in the brain. So these are just the most susceptible areas to clots with the worst outcomes. Brief word, they're bad. I need to get a new team of writers. It stinks. All right, so hypertension leads to arteriosclerosis. Arteriosclerosis then feeds back in and causes hypertension a little bit. So the direction, it's more of a cause here than it is the other way around, but it is nevertheless a positive feedback cycle. The blood vessels, so we have the tunica intima, the endothelium with the basement membrane with a layer of internal elastic tissue. Then we have the tunica media with the smooth muscle surrounded by the external elastic lamella. And then the adventitia, which is the tunica externa, which has lots of collagen and elastin and things like that. Big picture is the endothelial cells plus the basement membrane is the intima, followed by the media, which is the smooth muscles, followed by the externa, which is the collagen. So arterio means artery, and sclerosis means hardening, like a loss of elasticity. And there's really three different types: 1, 2, and 3. 2 is obviously the most important. Let's start with 1. Arteriolo, is for the small arterioles specifically, right? This is just a generic term. This is more specific for arterioles. And there's two types. Start with hyaline, and within hyaline, there's actually two causes. So hyaline is where the small arterial walls thicken, and then there's the one cause is that just chronic, long-term, benign hypertension, right? Maybe someone's blood pressure is 140 over 100. This slowly pushes out plasma and proteins. They're going to leak into the endothelium and cause it to thicken. Alternatively, diabetes mellitus might cause glycosylation of the basement membrane. You'll see this in the renal section. For the glomerulus especially, this hyaline arteriolosclerosis is very common. Alternatively, just an acute episode of very intense hypertension might lead to smooth muscle proliferation in the media, and this causes an onion skinning appearance. So notice the difference here versus here. And moving on to, let's do Munkeberg. Munkeberg is going to be the medium artery. So we have the small arteries, the medium arteries, and the large arteries. So the medium arteries, we're going to have calcification between the intima and the media. And so this is where the smooth muscle for the most part is. Intima, media, I guess there's the internal elastic lamina, and here we get a large thing of obstruction. Notice that this is actually the one type of arteriosclerosis that doesn't change the diameter, but it does change the stiffness. So the diameter is the same, but all of this calcium we have here, calcium just makes things hard, right? Think of your bones, they have calcium, they're hard. So this is going to cause intense hypertension because it's not giving. The elasticity is abrogated to some extent. Atherosclerosis is the big one. These are large arteries. This generates plaque. Plaque has fat, calcium, fibrin, and dead macrophages called foam cells. And this is all enclosed in a fibrous cap, which is really just like a layer of smooth muscle. So atherosclerosis, is the most common one, as we said. It's the largest arteries. The ones you should think of, the four big ones, are the abdominal aorta, the coronary, popliteal, and then the carotid, in that order. That's the pathogenesis, the risks. So gruel paste, why? Because, it kind of looks like gruel. My friend looked at this and said it looks like eggs and cheese. It's pretty gross. And just notice how tiny this little lumen is for the blood to get through. It used to be this, now it's this tiny thing. This one's even smaller, just so, 10% of the blood flow is getting through. Smoking, again, I can't say enough, this is a tremendous risk factor for atherosclerosis. Hypertension damages them. And then hyperlipidemia, which is the gruel, right? The fat gets in, and then the foam cells, macrophages eat the fat, which we'll talk about in a hot second. So hyperlipidemia is just when you have too many fats in your blood, too much LDL, too much cholesterol, etc. Often, there's a genetic component for sure. Sometimes people just have terrible diets, and a lot of times it's just both. So I would know that these fats can accumulate in the skin, especially the tendons. These are called xanthomas, especially on the Achilles tendons. And the eyes is going to be a common region as well. Okay, let's go into lots of details. Here's a nice little healthy blood vessel, all as well. Then, a little bit of fat. There's a damage with whether smoking or hypertension. A little bit of fat gets inside, moves past the endothelial cells into the basement membrane and the tunica intima. And then macrophages are going to extravasate, move through, and then they're going to gobble up the fat. They're thinking that they're doing a good thing by eating this LDL. But actually, they kind of eat so much that they explode, they die. And when they become, these apoptotic macrophages become foam cells, they're then going to secrete cytokines, which are going to recruit more macrophages to come in. They're going to also eat. They're also going to die. Then they're going to recruit even more. So you have a little bit of a positive feedback thing going here. All of these dead macrophages with these filled with fats. These are the foam cells. We're going to get calcium in the mix. Fibrin's going to come into the mix as well. Smooth muscle is going to migrate and start proliferating. So we get what's called a fatty streak first. That's like the first gross morphological sign. Then this is covered by the fibrous cap. The fibrous cap is really just going to be fibrin and collagen and smooth muscle that lies over it. And eventually, and so this is bad on its own, right? This is jutting out into the lumen. It makes it more difficult for blood to flow through because it's taking up some of the area. What's even worse, though, is that this might then rupture. It's very prone to rupture. A lot of this material is particularly thrombogenic, which means it's just going to initiate a really large clot really quickly, right? I mean, you cut your finger, look how quickly like the clot forms and dries. Same thing happens, if you're in a coronary artery. So weakened vessels, whether it's from hypertension or arteriosclerosis, and again, there is a reciprocal causation here. This leads to stiffened vessels, which exacerbates this, like I just said. It also puts extra strain on an overworked heart, and it causes aneurysms, and it can lead to dissections. And aneurysm is just when it juts out a little bit, so the diameter increases. And then a dissection is where you have a tear, specifically a tear in the media, and then blood can rush into this space. So for an aneurysm, they're most common in the abdominal region, but you can also have them in the thoracic, the ascending or descending, also in the aortic root. For the abdominal ones, back pain is going to be a big symptom, largely associated with tobacco use. For the thoracic, maybe think T for Turner syndrome with the bicuspid valves. I guess as long as we're throwing names out there, Marfan syndrome as well. Right? We have weakened connective tissue because we have an issue with fibrillin, which is necessary to scaffold for elastin. The aortic root dilation aneurysm specifically can cause regurgitation. And we remember from continuity equation that if we have a small cross-sectional area, the velocity increases. We remember from Bernoulli's equation that if the velocity increases, that means the pressure decreases. And so here I'm going to have a small pressure, which means at an aneurysm here, I'm going to have a larger pressure. This is a fusiform aneurysm, and then this is a saccular. So fusiform goes on both sides, saccular just goes on one side. This is what it looks like. It's kind of nuts. The aortic dissection, so it's really just all the same risk factors. And specifically what we have is, initially you'll have a tear in the intima, and then you'll have more significantly a dissection, a tearing of the media, and then blood can rush in. And if blood rushes in, it pools, and then it can rupture. And apparently these are just ridiculously painful. So someone's going to come in with absolutely like 10 out of 10 sudden onset chest pain and pain that radiates to the back, and it's apparently just very, very outrageous. It's very painful. This leads to an unequal blood pressure in the left and right arms as we're blocking some of these vessels. It's hard to know how the blood is going to be distributed, but it's unlikely to be equal. Type A is where the ascending aorta tears and blood leaks out. So it could be just localized to the aortic root, could be the entire aortic arch. Type B is really just after the aortic arch, really just for the descending part.